podcast. Today we're going to talk about PCOS, polycystic ovary syndrome. So let's imagine that there's two women, right? They sit in two different waiting rooms on the same afternoon and they walk out with the exact same diagnosis. Those three letters or four letters, PCOS, which is polycystic ovarian syndrome. And on paper, right, they have the same condition, but their lives are about to look very different. One of them will be pregnant within the year, more or less, on her own timeline. The other will spend the next 2 or 3 years cycling through specialists, medications, tears in the parking lot, and questions she can't shake. What is wrong with my body? Same three letters, right? Or same four letters, completely different roads. And here's the thing, the difference is not random, it's not luck. There is real science that explains why one woman with PCOS conceives easily and another struggles, why some cases are mild and some are serious, and why the label PCOS is honestly a little misleading because it's not one condition at all. It's a spectrum. So today we're going to walk into that entire spectrum together. What PCOS actually is, why it runs in families, why insulin, the blood sugar hormone, turns out to be the secret engine underneath the whole thing, why weight matters, and also why it isn't the whole story. And most importantly, what the research really says about fertility, which I promise you is far more hopeful than the fear that most women carry out of the waiting room. So let's get into it. Let's start with the name because the name causes a lot of unnecessary panic. Polycystic ovary syndrome. It sounds like your ovaries are full of dangerous cysts. They're not. Those cysts aren't really cysts in the way, you'd picture. They're not tumors. They're not going to burst. They are small, immature follicles. Each one is a tiny sac holding an egg that started to develop and then stalled out because it could be released. So hold that picture in your mind because it's the picture for the whole episode, not damaged ovaries, but ovaries full of eggs that got stuck partway through the process. And PCOS is the single most common hormonal disorder in women of reproductive age. Depending on which definition you use, somewhere between 5 and 13% of women have it. And that's roughly 1 in 10. It's a lot. So if you have PCOS, so it's really three words, and you feel alone with it, understand that you are surrounded statistically by women carrying the same thing quietly. And it is the number one cause of infertility that comes from not ovulating regularly. Now, how do doctors actually decide if you have it? Here is an international standard called the Rotterdam criteria, and the logic is simple. There are three key features, and you need any two of the three to be diagnosed. So, feature one, regular or absent ovulation. In plain terms, periods that are far apart, unpredictable, or missing altogether. Cycles longer than 35 days or fewer than about 8 periods in a year are the classic pattern. Feature two, high androgens. Androgens are the hormones we tend to label male, right? Testosterone is the famous one, but women make them too, normally in small amounts. In PCOS, they can run high, and that shows up in visible ways: acne that lingers past the teenage years, extra hair growth on the face, chin, or body, and sometimes thinning hair at the crown or the scalp. Or it doesn't show up on the outside at all and only turns up, in a blood test. So, feature three, the polycystic appearance on ultrasound, that classic look of small follicles arranged around the ovary. And here's a genuinely useful update. As of the 2023 international guideline, doctors can now use a blood test called AMH, anti Mullerian hormone, as an alternative to the ultrasound in adult women. AMH is produced by all those little follicles, so a high level tells a similar story. It's cheaper, more convenient, and doesn't require a transvaginal scan. So, 2 of 3 sit with that for a second because it's the master key to today's whole conversation. Two two of the 3 means you can arrive at PCOS through different doors. One woman has irregular periods and high testosterone. Another one has high testosterone and the ovaries on ultrasound, but perfectly regular cycles. A third has irregular cycles and the ovaries, but totally normal androgens. All 3 get the same label, and yet their bodies are behaving differently. So that's why no two PCOS stories are quite the same. And it's why the next part matters so much. Researchers took that 2 out of 3 idea and mapped out every possible combination. And it gives you, 4 versions really of PCOS. They call them phenotypes and they label them A, B, C, and D. So, don't get hung up on the letters. Just follow the logic because this is the direct answer to why are some cases worse than others, right? Phenotype A is the complete classic version. All 3 features are once at once. So high androgens, irregular ovulation, and the polycystic ovaries. This is what people historically picture as like textbook, PCOS, and on average, it is the most metabolically serious form, the most insulin resistance, the most difficult with weight and blood sugar, the highest MAH levels, and often the hardest fertility road. Now, phenotype B is high androgens plus irregular ovulation but ovaries that look normal on the scan. Still on the more serious side of the spectrum because you've got the 2 features that matter most for fertility and metabolism, the hormone imbalance and the ovulation problem firing together. Now, phenotype C is the fascinating one for fertility. This is high androgens and the polycystic ovaries, but the woman still ovulates on a regular cycle. Doctors literally call this ovulatory PCOS. And because she's still releasing an egg most months, her odds of conceiving on her own are dramatically better than someone who isn't ovulating. Now, metabolically phenotype C also tends to be the mildest of the classic types. Studies find these women are far more likely to be a normal weight and to have normal insulin and cholesterol numbers. Now, phenotype D is irregular ovulation and polycystic ovaries, but normal androgens, no excess testosterone at all. And this is often the gentlest metabolic picture of the group. So when someone asks, why is my friend's PCOS so much milder than mine? This is the answer. Severity tracks with 2 things above all, whether you're still ovulating and how far out of balance your androgens and your insulin are. The versions that combine skipped ovulation with high androgens carry the most metabolic weight and the most fertility difficulty. Now, the versions that keep ovulating or keep androgens normal tend to be easier in nearly every front: fertility, blood sugar, heart health, all of it. And this isn't just academic tidiness, right? It's when researchers follow pregnancies. The phenotypes that combine skipped ovulation with the polycystic ovary pattern show higher rates of pregnancy complications. So these subtypes genuinely behave like different conditions inside the body. That's the single most useful thing to take your to your own doctor. Don't just ask, "Do I have PCOS?" Ask, "Which type do I have? And what does that mean specifically for me?" A question I get constantly. Did I do this to myself? Did I cause my PCOS? And the honest research backed answer is largely no. PCOS has a powerful genetic backbone. The clearest evidence comes from twin studies. When researchers compared identical twins who share essentially all their genes to non identical twins who share about half of their genes, they can estimate how much of a condition is inherited. Now, for PCOS, those studies put the heritability, am I saying that right? Somewhere around 70%. 70, that's high. And in the same neighborhood as height. It means the lion's share of your risk was written before you were born. And you can see it in families too. Daughters of women with PCOS have a much higher chance of developing it. One large family study found roughly a five-fold increase. And it isn't only the women. Male relatives of women with PCOS show higher rates of insulin resistance, early hair loss, and type 2 diabetes. Now, brothers, fathers, mothers, and even young daughters of affected women can carry the metabolic and hormonal fingerprints. PCOS is really a family metabolic trait that happens to express itself most visibly in the ovaries. Now, here's the honest scientific frontier. When researchers go hunting for the exact genes in what are called genome wide association studies, they found around 20 to 30 locations in the genome that raise the risk. These genes cluster in sensible places, genes that control androgen production, genes involved in insulin signaling, genes that manage the brain to ovary hormonal signals, and genes tied to follicle development and AMH. But here's the twist, and add up all the common genes they found, and it only explains under 10% of that 70% heritability. Scientists call this the missing heritability. The current thinking is that rare genetic variants and epigenetics, the way genes get switched on and off, possibly even influenced by the environment in the womb, fill in much of the rest. So, why does this matter for a real person and not just a geneticist? There's two reasons. First, it should lift some guilt. It shouldn't lift or it you didn't cause the underlying conditions with your choices. But second, and this is the empowering half, genes load the gun and lifestyle environment often pull the trigger or they don't. Your DNA sets your susceptibility. How that susceptibility expresses itself, how severe it gets, how much it affects your fertility and your long term health is something you and your care team can genuinely influence. Which brings us to the engine room. So, if you understand one mechanism in this entire episode, make it this one because it ties everything together. The engine underneath a huge amount of PCOS is insulin resistance. Quick refresher, insulin is the hormone that ushers sugar out of your bloodstream into your cells to be used for energy. And insulin resistance, your cells stop listening to insulin the way they should. So your body does the logical thing. It shouts louder. It pumps out more and more insulin to force the sugar where it needs to go. The blood sugar may look fine on a basic test, but behind the scenes, you've now got chronically high insulin circulating throughout your body all day long. Now, that's the key state, high insulin. And high insulin does two very specific, very unhelpful things inside the ovary. First, It directly signals the ovary to crank up the androgen production, more testosterone. So the insulin problem and the high androgen problem aren't two separate issues. One feeds the other. And that's why they so often travel together. Second, high insulin scrambles the delicate hormonal conversation between your brain and your ovaries. The signaling that's supposed to select one follicle each month and mature it all the way to ovulation. Instead of one follicle taking the lead and releasing an egg, a whole crowd of follicles get stuck part way. They arrest and that arrested crowd is exactly the polycystic look on the ultrasound. So follow the chain, right? So insulin resistance drives high insulin drives high androgen and disruptive brain ovary signaling. And that disruption stalls the follicles so ovulation doesn't even happen. No released egg means no period and no chance to conceive that cycle. Run that pattern month after month, year after year, and you get that irregular cycle and the infertility that PCOS is known for. Many women who have PCOS feel like it's a death sentence for having children. And that single loop explains an enormous amount of what women with PCOS live with. And it's exactly why the women with ovulatory phenotype C, who has less of this metabolic disruption, keeps ovulating and conceives more easily. It's also the perfect moment to pause for a word from a sponsor who works on precisely this loop. If everything I just said about insulin made you lean in, today's episode is brought to you by Larson Nutrition. And here's why this belongs in this exact conversation. That insulin and androgen loop I just walked you through, that is the precise thing that Larson Nutrition helps women work on. I built this practice after my own metabolic wake up call. Prediabetes, high triglycerides, blood pressure climbing, and instead of accepting a lifetime of prescription, I went deep into the science of metabolic nutrition and rebuilt my health. Today, my team has worked with more than 3,000 clients on exactly these issues: insulin resistance, prediabetes, metabolic syndrome, and PCOS specifically. And what I appreciate is that it isn't a genetic diet handout, it's personalized nutrition protocols built around your actual numbers, real biomarker monitoring so you can see what's changing, and weekly one on one accountability coaching. Because with insulin resistance, the whole game is consistency over time. And to be clear, this is nutrition and lifestyle coaching. It's not a replacement for your doctor or your fertility specialist. Think of it as the metabolic foundation that makes everything else work better. If you want to address the root cause, level metabolic piece of your PCOS, go find them at larsonnutrition.com. That's larsonnutrition.com. Now, let's tackle one of the most painful misconceptions out there, that PCOS is simply a weight problem, and that if a woman would just lose weight, it would all go away. Well, the research tells a more nuanced and frankly more compassionate story. It's true that most women diagnosed with PCOS, roughly 80%, are overweight or have obesity, and carrying extra weight, especially around the middle section, genuinely worsens insulin resistance and makes every symptom louder. But about 1 in 5 women with PCOS is lean, normal weight, sometimes slim. I know several women who have PCOS who are very lean. They're at normal weight, sometimes very slim, and they still have full-blown PCOS. This is what's called lean PCOS, and it shatters the idea that this is just about body size. And here's the striking part: insulin resistance shows up in lean women with PCOS too. Studies estimate that something like 75% of lean women with PCOS have insulin resistance, compared with around 95% of those who are overweight. So weight amplifies the problem, but the underlying metabolic glitch is baked into the condition itself, independent of the scale. So researchers describe it this way. Lean women with PCOS have an intrinsic built-in insulin resistance that's part of the syndrome, while heavier women have that same intrinsic resistance plus an added layer that comes from the excess weight. So, two sources stacked on top of each other. This has real consequences. A lean woman with PCOS is often told she can't have it or gets dismissed, and her metabolic issues go unmonitored precisely because she doesn't fit the stereotype. But her cholesterol, her insulin, her long term diabetes risk still deserve attention. And there's an interesting research debate that body weight may actually predict a woman's metabolic health even more powerfully than her Rotterdam phenotype does. Meaning, the number one, the number on the scale and the number on her insulin panel can matter as much as which letter, A through D, she was assigned. So the takeaway for every listener, whatever your size, PCOS is a metabolic and hormonal condition, not a moral failing and not a simple matter of willpower. And it means that managing it well is about metabolic health, how your body handles insulin and sugar, far more than it's about, a number on the scale. Okay. The question that brings so many women to this topic in the first place: why can one woman with PCOS get pregnant without much trouble and another can't? After everything we've covered, the answer comes down to one word: ovulation. Are you getting ovulation? To conceive naturally, you have to release a mature egg. That's ovulation. In PCOS, for many women, that's the step that breaks down. The follicles stall. And as we described, and no egg is released. No egg, no pregnancy that month. The women, the woman in the ovulatory phenotype that's still releasing eggs sails past this obstacle. The woman whose ovulation has gone quiet hits every single cycle. But here's the part that genuinely surprises people. And I want to say it clearly because it's the opposite of what most women fear. Women with PCOS are usually not running low on eggs. It's almost the reverse. They tend to have a higher than average number of eggs sitting in the ovary. That's why the AMH level is high and why the ovary looks so full and busy on the scan. So the problem is not supply. Your ovaries are not empty. The problem is release. The eggs are there, often in abundance. They're just getting stuck before the finish line. So this reframe matters emotionally, not just biologically. So many women hear infertility and picture a barren, empty ovary, a clock that's run out. And for PCOS, that picture is usually wrong. It's much more accurate to picture a room absolutely full of candidates and a doorway that isn't opening reliably. And a doorway that's stuck is often something medicine can open or help open, which is exactly where we go next. When help is needed, doctors think of it as let's say, a ladder. You start at the bottom rung, and most women never have to climb very far. So let's walk it. Rung one is lifestyle. And this is not a throwaway line because insulin resistance sits at the center. Improving how your body handles insulin can restart ovulation on its own. For women carrying extra weight, even a modest loss in the range of 5 to 10% of body weight can be enough to bring cycles back. That's not a guarantee for everyone, and it's genuinely harder to lose weight when your insulin is working against you. So, this is not about willpower or crash diets. It's about a sustainable, metabolically smart approach to food, movement, sleep, and stress. And this is the foundation the entire ladder rests on. Rung two, if you need medication to ovulate for years to go to drug was clomiphene. But the current international guideline now names a medication called letrozole as the preferred first choice for most women with PCOS. And in the big head-to-head trial, letrozole produced more live births than clomiphene, roughly 27% versus 19%, with a lower chance of twins. And it's a short course of pills taken early in the cycle. One honest footnote, letrozole is technically used off label for fertility because it was originally a breast cancer drug, but the evidence supports it for ovulation is now strong and reassuring, including on safety. Alongside that, a few important supporting players. Metformin is a diabetic medication that improves insulin sensitivity. It's often used in PCOS to help with the metabolic side and sometimes to support ovulation. Then there's inositol, specifically a combination of myoinositol and dechiro-inositol, usually in a 40 to 1 ratio. Inositols act as helpers in the body's insulin signaling, and they show up in a lot of prenatal and PCOS supplements. And the evidence is encouraging for improving insulin measures and menstrual regularity, and they're very well tolerated. Though the 2023 guideline is measured about uh, the guideline is measured about it, nothing limited, noting limited harm and some metabolic benefit, but only modest proof of clinical fertility benefit. Worth an honest conversation with your doctor rather than a miracle cure explanation. So, a newer entry worth mentioning, the GLP-1 medications, names like semaglutide, the same class as Ozempic and Wegovy, for women with PCOS and significant weight to lose. These can meaningfully improve weight and metabolic markers. And research interest is intense, but two big cautions. There are generally they are generally reserved for higher BMI or weight-related health conditions. And critically, they are not fertility drugs and are not safe to use while trying to conceive or during pregnancy. In fact, because they can improve metabolism quickly, they can trigger unexpected ovulation. So reliable contraception is advised while on GLP-1s with a washout period before trying for a baby. This is very much a talk to your doctor area. And the higher rungs, when they're needed, if oral medications don't do the job, there are injectable hormones called gonadotropins, a minor ovarian procedure, and ultimately IVF, in vitro fertilization, which tends to work well in PCOS, precisely because there are so many eggs to work with. And the whole point of the ladder, though, is that the great majority of women get what they need on the lower rungs. IVF is a tool that's there if you need it, not a destination everyone reaches. Now, the part I most want women to actually hear, because the fear around PCOS and fertility is very often bigger than the facts. Many women with PCOS have children. Let me say that plainly because it gets lost. The majority conceive, some entirely on their own, many with the kind of help we just described with IVF or medications. So when researchers follow women across their whole reproductive lives into their 40s, the family size of women with PCOS end up close to those of women without it. Let me say that again. When researchers follow women across their whole reproductive lives into their 40s, the family size of women with PCOS end up close to those of women without PCOS. In one large 25-year study, women with PCOS did have slightly fewer children on average and were more likely to have their first baby at a later age. But they had the same family aspirations, and a great many of them got there. It often takes a bit longer and it may take some medical help, but the destination is frequently the same. There's even reassuring data going all the way back to adolescence. Girls with irregular PCOS type cycles as teenagers, the very pattern that feels so ominous, overwhelmingly went on to conceive, most of them delivering at least one child, many without ever needing treatment. So, if you're a young woman listening or a mother worried about a teenage daughter's irregular periods, please hold on to that. I'll give you one honest caveat because I promised you real science and not just comfort. Pregnancy with PCOS does carry somewhat higher risks, such as gestational diabetes and high blood pressure in pregnancy are more common, roughly a couple of times more likely. And there's a modestly higher chance of preterm delivery. But notice what that means. It's a reason for good, attentive prenatal care, not a reason for fear. Getting pregnant is one milestone. It's a well monitored pregnancy is the next one, and it's very achievable. So let's close on the part no lab test measures. PCOS is a long haul companion. It's more than fertility. It's the acne and the hair changes that affect how you feel in your own skin. It's the irregular cycles that make planning hard. It's the elevated long term risks like type 2 diabetes and heart health that need lifelong attention. And it's a real, well documented mental health load. Anxiety and depression are meaningful, more common in women with PCOS. And that is not a weakness or oversensitivity. It's part of the condition and it deserves real support, not a brush off. So, managing PCOS well includes managing yourself well. Chronic stress isn't just unpleasant, it nudges the very hormonal systems that are already off balance. You need rest, recovery, tending to your body from the outside in. And that's not indulgence, it's maintenance for a body that's working hard. Which brings me to our second sponsor. Today's episode is also sponsored by Larson Botanicals. If Larson Nutrition is about caring for your body from the inside, Larson Botanicals is the outside and companion. Organic ingredient skincare and handcrafted candles made clean without the junk you don't want sitting on your skin or burning in your home. It's all plant powered self care that locals are raving about. Now, I'm not going to tell you a candle balances your hormones, it won't. And I'd never insult you like that. So, what I will say is this: when you're managing something as relentless and as daily as PCOS, the small rituals genuinely matter. A skincare routine that feels good on a hard morning, a candle lit at the end of a long day, a few quiet minutes that belong only to you. Now, that kind of care is a part of the bigger picture, right? Of living well with this. So treat yourself to something clean and calming at larsonbotanicals.com. That's Larson, Larson, botanicals.com. Beauty that feels good and does good for you. Now let's bring it all home. If you remember nothing else from today, remember these 5 things. One, PCOS isn't one thing. It's a spectrum sorted into types. And when you land Where you land shapes everything from your fertility to your long-term health. Ask your doctor which type you have. 2, it's largely genetic. You didn't cause the underlying condition, but how expresses itself something can influence. So we talk about this frequently in functional nutrition. You might have the gene for it, but you load the gun by how you consume foods, what kind of supplements do you take to support your body, and eating clean ingredients. 3, insulin is the hidden engine. The blood sugar hormone drives high androgens and the stalled ovulation, whether you're lean or not, which means your metabolic health is your fertility health. It's so important that you eat clean. Don't be eating beef sandwiches and burgers and french fries and onion rings and sugar and highly processed foods, spaghettios and garbage like that. Pizza, going out all to eat all the time, Burger King and McDonald's and Culver's and all this junk food that's out there. Eat whole, clean food. Get your chicken and vegetables. We just boiled up organic chicken. We're chopping up onions and garlic. We're going to chop up the carrots we have. We're going to put that all into a pot. We boil the bones, and we're going to put in the sliced chicken and the bones that we got the collagen and the good fats from the skin and the bones. And we're going to make a nice soup from it. Happy 4th of July. Even though it's hot outside, we're going to make some delicious soup, and we might even eat it cold. So 4, the fertility problem is usually about releasing eggs, not running out of them. Your ovaries are typically full. The doorway is stuck, and medicine is often very good at helping opening it. 5, and carry this one out the door with you. The odds are far more hopeful than the fear. The great majority of women with PCOS build the families they hope for. The path may look different, but the path is very often there. If this helped you understand your own body or helped you understand someone you love, please share it with her. That's how this reaches the women in the waiting room who needs it. And thank you to our sponsors, Larson Nutrition, Larson Botanicals. Take good care of yourself, and I'll see you